started just to be mindful of the time. We've had a little bit change in the schedule. We had our patient perspective, our patients that were going to be on the Dysons. Unfortunately, one is under the weather, and so they're unable to join. So we've had to course correct a little bit. Also, Dr. Ward is not going to be here, but Dr. Seacrest will be showing up hopefully any minute. He just emailed me. So he'll be hopping on here. But we're going to have Lauren Ruiz do a little bit of a didactic presentation again with some Q&A. We can also open it up for just general Q&A around MS. So if there's any other topics you want to talk about, we can do that. So we appreciate you being here and kind of rolling with us here as the schedule has changed a little bit. But I'll be mindful of the chat. So put any questions or anything like that in the chat. I can track that. And Lauren and Sarah, I'll turn it over to you guys. You both should have capabilities to share your screen or do whatever you need to do, but go ahead and take it away.
Thank you so much, Jay. And I just want to confirm with everybody that you are seeing my screen with a slide that says Enhancing Disability Access in Clinical Care Settings. Great. Thank you so much, Jay, for confirming that. I will try to keep an eye on the chat. If you see me all sort of glancing up to my side, it's because I have you on a side screen and I want to look at you all. But I'm going to try to do my best to stay focused, straightforward, and give the presentation. So welcome. Discussing disability access in clinical care settings. As Jay mentioned, I'm Lauren Ruiz. I'm a senior program manager with the Institute for Public Health Innovation. And my so far 15-year career in nonprofit patient support services has always centered around increasing access to and utilization of health and social support resources for people living with and impacted by complex chronic diseases, particularly my soft spot for neurologic and neurodegenerative diseases. So one of the first things that I want to do is set the context. I receive calls and emails and text messages from patients and caregivers that I've worked with over the past 15 years very consistently, almost every day, saying, Lauren, you'll never believe what just happened to me. And a lot of their times, their stories really center around this idea of access. It's not always in the clinical space. We'll get to those examples in just a moment, but I wanted to share a few that have really resonated with Sarah and I over the years. The first is a quote from a gentleman who was traveling with his family when his wheelchair was broken by flight crew members. Not only did this affect his ability to be independently mobile during their trip, but the replacement chair that he was provided was not made for him and did not fit his body and his size. So this led to severe discomfort and increased pain during and after the trip. It also has discouraged him and his family from traveling. The next quote is from a dear friend of mine, Miss Christine, and this woman attended a conference actually hosted by her disease-specific patient association, and she was a featured speaker. So they knew her well, they knew her condition well, and they knew her mobility challenges well. Throughout the conference event, she still found herself unable to navigate the space due to repeated space limitations and physical barriers. Even when it was her turn to speak, a ramp had been placed near the stage, but no pathway was created for her to actually reach it. And in this third example, this patient lives in a rural area and they traveled to a new clinic to receive care. After the somewhat significant energy resources that it took them just to get there that day, she arrived only to find what seemed like a monumentous challenge ahead of her, which was multiple flights of stairs. Ultimately, in talking with her, her comment about the visit was that it was not good, and she often hesitates now to go places that she's not already familiar with. So how does all of this translate into clinical care and our ability to provide more equitable access to those living with disabilities? The information on the following slides about physical access in clinical care settings has been adapted from resources and information by the Center for Medicare and Medicaid Services, CMS, and the American Medical Association. So as you can see from this information from those resources, people living with disabilities are at a higher risk of developing poorer health outcomes. And this is not only due to the primary underlying health condition or impairment, but often exacerbated by these unmet health needs that they experience due to access and barriers to receiving health services and quality care. So we want to look at this framework for disability definition as we talk about what we can do to address these limitations and hopefully lead to better health outcomes. According to the World Health Organization, disability has 3 dimensions: impairment, activity limitation, and participation restriction. And you can see how these sort of build on each other. Impairment is the physical or mental change from the baseline in the person's body or mind. So what has happened to them? The activity limitation is how the impairment affects that person's ability to do something. So if they have a loss of vision, that may lead to difficulty seeing, for example. And then finally, the participation restriction is the impact that the activity limitation has on the person. So how is this impacting their day-to-day interaction with the world and environments around them? If these things go unaddressed, then we see these poor health outcomes, these feelings of isolation, and ultimately a lack of trust with the health system. But addressing these issues can reverse or prevent these outcomes and create more opportunities for increased participation. But we really do need intentional planning and inclusive design to address participation restriction. And this is what we're going to focus on today. So very quickly on those other 2 fronts, we need cures and treatments to address the impairment. The clinical diagnosis relates to that impairment. So by identifying that impairment, we can move toward a treatment or a cure. Similarly, we need medical equipment or other support tools to address an activity limitation. The functional status relates to the activity limitation. By identifying that activity limitation, the provider can recommend and deliver tools to address that limitation. So who is this all affecting? If we go by the estimated adult population of the United States in 2022, roughly 13% of that would be almost 34 million people. And in rural areas, which often have what are called graying populations or aging populations, those self-reported instances of disability become more prevalent. And the reality for many of these individuals
Lauren?
is that they have difficulty accessing the health service. Yes.
You seem to be breaking up a little bit on my end. You might need to turn your camera off, unfortunately. It's kind of, it's catching up, but there's a little bit of a lag.
Okay. I'll try that, Jay. Thank you. You guys can let me know if this helps. But the reality for many of these individuals is that they have difficulty accessing the health services they need. And sometimes they just don't because of that. So how can we sort of break this cycle? When they aren't accessing the services or participating, we're really losing those opportunities to address the functional status or the activity limitation. We lose that opportunity to address that clinical diagnosis or impairment. Really, ultimately, we're losing that ability to address the causes and the sources of the disability and the outcomes. That leads to decreased functional status. That leads to more and more participation restriction that results in more disparities and more disability. So by reversing this cycle, patients can better access the services they need and then have better access to those solutions for activity limitations and impairments, which will result in those improved health outcomes. So we're talking about equal access. What are we really meaning? This is providing equal access to healthcare for people with physical disabilities, and it involves many factors, which include facility access and healthcare service access, among others. So when we think about your facility access, this is how the individual is getting into the facility itself. This may mean accessible routes from parking or bus stops into the building, accessible parking at the location, accessible entry doors, clear floor space, etc. And then once they get inside of the facility, they still need to navigate not only the space, but the processes and services. So think about accessibility throughout that process for the patient, from check-in to check-out, and we'll go into more detail about that on later slides. So there are a multitude of laws and policies that guide and regulate rules impacting disability access. Some settings may or may not be subject to all of these laws. However, legal accountability is not necessarily the only consideration that we should make when determining your organization's responsibility to provide an accessible facility and services to the people that you serve. Generally, these rules require healthcare organizations to provide equal services, make reasonable modifications, and provide supplemental equipment or services, particularly to facilitate communication activities. So finally, let's put some of these ideas into practice. How can you actually improve physical accessibility at your healthcare facility? To begin addressing the barriers to physical access, we need to understand what they are. These are some of the most common barriers patients report facing when attempting to access a physical space leading or inside the clinic. They may come into contact with issues with parking, not having van accessible parking spaces, so they park, but then they can't really get out. Or once they're out, maybe they can't make it all the way up to the building. This could be due to issues with ramps, stairs, sidewalks, or doors. We often see with ramps that they change direction too quickly, are too narrow, too short, too steep, lack handrails or other things that can help people as they're walking up that pathway from falling. Stairs similarly need those handrails not only on the stairs themselves, but extending horizontally at the landings at the top and bottom so that the individuals have some time coming off of those stairs to gain and maintain their balance and position. Once you're inside the facility, do your doors open with sufficient clearance? Are they too narrow? Do they have really difficult latches that restrict someone's ability to open the door? And do you have sufficient bathroom space for those with physical disabilities and needs? The first step to taking action is to assess those potential barriers in your physical space. The ADA provides helpful standards that can guide you to identify if a barrier exists and what may need to change to address that issue and make it more accessible. Then we want to think about each phase of navigation that the patient may need to do in order to complete the visit. Are there barriers during the check-in process that we may be able to address? What about the restrooms and other shared spaces? And once they get called back, how are they navigating the hallways, the entryways, and particularly exam rooms? So let's remember that not every change needs to be a change to the physical space. Sometimes just a little bit of extra training, awareness, or intention in the design of your organization's policies can make a huge difference. Improving the patient's ability to navigate the physical space and the processes will both have impact and make your services more equitable. So review and update your scheduling procedures to make that a simple process for your clients. Make sure that your check-in procedures are consistent and that they include protocols for responding to a patient's need. Provide training and opportunities for different staff members to interact with and provide solutions for clients with disabilities. And most importantly, leverage as many resources as you can to support these practice changes. This might include networking with other providers in a similar environment or with similar client demographics, reaching out to local disability organizations and seeking guidance or an assessment, and exploring tax incentives, which we'll talk about next. So for many providers, these all sound like great, super helpful ideas, but they might also sound kind of expensive. And yes, we understand that some changes, particularly when we're talking about changes to a physical space, can seem costly. But there are programs that can help to offset some of those costs. Tax incentives are available at different levels to offset some of the costs of improving facility accessibility in particular. The IRS runs two programs, the Disabled Access Credit and the federal tax deduction that many healthcare providers may be eligible for to help them remove these barriers in their existing facilities. Additionally, the trust that you will build with your community will increase utilization of services and retention of patients, leading to that more sustained source of income through service to your clients. These are some guidelines, assessment tools, and resources that can help you as you consider assessing and providing solutions to barriers in your physical clinical space. We'll make these available through the session, or you can always reach out to IPHI, Sarah and I, and we're happy to provide these resources and others. So I know we've talked a lot about the physical space today, but I think it's wise to acknowledge, especially in the context of how we're meeting and interacting today, that we increasingly find ourselves in virtual spaces. So telehealth can be one of those solutions to participation restrictions and activity limitations. We've seen through COVID and after telehealth and teleconferencing expand opportunities for people with disabilities to engage. But there are unique challenges specific to telehealth and teleconferencing that need to be considered when implementing this type of technology as a solution. Because as these technologies become more generally accepted and accessible, we want to ensure that they undergo that growth on an equitable path and that people with disabilities are not being left behind. So while some significant challenges may exist for patients with disabilities when it comes to accessing both in-person and remote healthcare, we know that we can overcome these. And particularly with the remote healthcare, it's communication access barriers that we often see preventing patients with disabilities from fully utilizing that teleresource. So when we think about ADA telehealth considerations, they've created this really simple tool that can just be a good guide for thinking about how you may be designing, implementing, or delivering your telehealth. You might want to think about access and how the patients are going to be accessing your services. I know myself, I recently had to buy a computer to try to complete my public service student loan forgiveness forms because there's no way that I can do that on my smartphone. I've been trying for a long time and I finally had to just make that leap. So there might be different tools that your clients have that limit their ability to participate in certain services. So understanding that and recommending the right tools and services is important. You also want to think about, once they get started with that technology, what are some of those limitations that they may have that could reduce their participation? This may be some of those limitations around vision, hearing, memory and attention, or mobility. So this resource and others have many tips and best practices about how to design and implement your telehealth so that you're addressing these potential barriers up front. So specifically, let's dive into some of those limitations that you. If you're treating patients who are deaf or have hearing loss, these are some of the recommended best practices to ensure that they're able to fully utilize that technology and participate in your visit. This may include providing text on screen to help them, making sure that you're on camera and have a stable internet connection to be on camera so that they can read your lips and see your visual clues like gestures. Use a quality microphone or headset. And try to send materials up front in written format prior to and post appointment so that they can really reference back to those. Because if there were communication gaps during the visit, those can be filled and addressed and followed up on through those additional supplemental materials. Similarly, treating patients who are blind or have vision loss comes with limitations, but also tools to help them still fully participate. If you are on camera, be aware of your background and try to have something that's high contrast. That blurring feature may make it challenging for some patients to really pay attention and focus on and see clearly what's happening on screen. Ensure that your lighting is bright enough to be seen. And again, if you are providing text, make sure that it's simple and enlarged so that they can see it, and that you're providing any access to tools that may help to facilitate these limitation barrier solutions. And finally, a little bit more complex, only because the spectrum of people living with physical and developmental disabilities has so many different iterations and symptoms than just necessarily hearing or vision loss. So in these situations, it may be helpful to work directly with the patient in their home if the goal is to provide ongoing telemedicine care. And that's really to assess and address solutions in their environment and space that may be restricting their participation. There are also resources through written resources, but also human resources that can be really helpful to consult when you're have a specific patient or are considering how to serve this type of demographic. But these individuals may have expertise in assistive technology or rehabilitation and can recommend and provide tools that can help that patient to interact with the required technologies. If the patient does have a particular diagnosis and an affiliated patient disease support program, those programs often also have resources and recommendations for assistive technology tools that are very specific to the needs of that individual's disability. And again, when we think about providing these services, cost is always a concern. So what can we do to consider reducing financial barriers for providers looking to provide telehealth and teleconferencing services? The Universal Service Fund is a pool of money that's earmarked by the federal government to increase access to advanced telecommunication services throughout the nation at just, reasonable, and affordable rates. This program is administered by a private company, the USAC, or the Universal Service Administrative Company, and it receives funds exceeding about $700 million each year. Repeat that number, $700 million each year of funds that are available and up for grabs for organizations just like yours to get assistance financially to provide these types of technologies and close that digital divide. These funds are collected from telecommunications companies as a fee under the Telecommunications Act of 1996. So that's something else I feel really great about, is that the funds are coming from those big corporate organizations that we all pay hundreds of dollars to every month for our own internet services. So a little piece of that is put back into this pool and is made accessible to try to, again, close that digital divide. One particular program of interest, the Universal Service Fund administers 4 rural healthcare program. This program, do you have a question, Jay?
About the name of the program, if you could repeat that.
Yes, the Rural Health Care Program. This is one of the 4 programs administered through the Universal Service Fund. And it supports healthcare facilities in bringing this world-class medical care to rural areas through increased connectivity. So this program provides financial support for voice and data services and or broadband services, because you can apply to and receive funds from both of these services at the same time if you qualify. USAC offers technical assistance and support throughout the eligibility determination and application processes. So this is not something that you have to do on your own. That is a great question, Michelle. This service is the Rural Healthcare Program is for companies, but there are services for individuals through the Universal Service Fund, like the Lifeline program, for example. So their website is linked here. It links to the Rural Healthcare Program, but you can access information about all 4 programs through that website, or reach out to us with more specific questions, and we're happy to provide those direct links and contacts. These are also just some additional resources that we utilized to put this training together, and that we have used in the past or other partners have used to implement their telehealth programs. In addition, more in-depth trainings about telehealth are available through provider education programs. So if you are currently delivering telehealth services or looking to do this in your practice, these trainings can be really useful in helping you to understand how to best deliver telehealth appointments, how to set up your telehealth space for success, how to implement and sustain these services, and even how to prepare your patients for appointments, amongst other topics. So please reach out to us if you have any questions, particular scenarios that you want to go over, or looking for specific resources for your organization. We are more than happy to talk to you about your particular situation, needs, and what might be most helpful. But for any available time that we do have left, we would love to hear from folks, any questions that you have, and then discuss any of those questions that you see on screen, or share best practices and resources that you may have or know of.
Thank you, Lauren. That was great. A lot of information. Just to reiterate, we will share all the information with the links and everything like that in the recap email and things. So don't worry about it if you missed it or anything like that. But please unmute. Feel free to answer or ask any question or provide any information, like Lauren said.
I was going to add, I know I've heard from a lot of folks when they talk about receiving clinical care, there's a lot of highlights on access to the clinic, as well as the equipment. And that's a common concern that I've heard from folks. They'll go to have their eyes checked, but they can't utilize the equipment that's available at the optometrist office, or they will go and to get the diagnostic tool or treatment tool. It's not always accessible. So something to think about when purchasing equipment for clinical spaces, and having those conversations with the equipment providers as well.
Dr. Seacrest, I saw you unmute kind of at the same time as Sarah. Did you have anything to add there? Yeah.
Just to chime in, it's good talk. We spent a lot of time in the clinic on symptom management, and that's kind of a big part is why is trying to manage the disability. Sorry, I'm wandering through the hustle. And it is really tough. And every now and then we'll get someone from another state who has really restricted mobility, and it's really hard for them to get to the clinic. And then once they get here once, there's a whole lot to do, and we need to see them back soon, and then it's not even practical. And then we can't do a telehealth because they're in a different state, and you need a license in that state to be able to do it, even though they're like maybe 10 miles over the border. So we run into that a decent amount, and it's extremely frustrating. Just that barrier to access because of arbitrary state lines, which wasn't a thing during COVID, but they brought it back.
Yeah, we hear the state line thing about all conditions, all family medicine, all that's always a big thing is, where are you located? Can you get on the right side of the line, essentially?
Yeah, it gets really hard. So then we end up treating patients from Maryland or Pennsylvania a little bit differently than we would if they're West Virginia, which feels wrong, but we kind of don't have a choice.
This might be a really naive question of me, but you're talking about the ramps, and you're talking about the physical kind of access to your clinic and stuff. are there checks? Is there a group that comes in and just does those checks to make sure you're meeting all those requirements? I have a feeling the answer is yes, but I just, in my head, as I was reading that, I'm like, somebody has to be checking on that, right? About the ramps and your doors open wide enough and all that.
So that really depends, Jay. Like I said, many of those laws are only applicable to very specific providers. So, for example, if you're not serving Medicare patients, then you're not held to any of those Medicare specific accessibility rules. And so it's typically more of like the federally qualified health centers and those that have that type of oversight that may receive visits more frequently and have that kind of more in-depth oversight. And so we certainly see at smaller practices that they may not have always made or had the opportunity to make some of those updates to their facilities. And in some cases, they may not be required to, or they may be able to get exceptions or extensions on implementing some of those changes. And so that, yeah, it's sometimes hard to point at a particular site and say they're definitely breaking the law. But again, I would hope that for most providers, legality is not the only consideration that we're making when we're thinking about our responsibility to provide this type of access. And so I really think that putting a focus on the resources that are available to help providers make these changes is the most effective tool right now, because we really want to encourage folks to do what they can. Even if it's making small changes at first, that can lead to more opportunity or better access, even on an incremental scale. And that's always important. So, don't necessarily look at your facility and see a huge project ahead of you. May focus on one thing and do that assessment and try to just reduce some of those smaller barriers, get some of those easy wins in, and really familiarize yourself more with those resources that are available, because they are out there, and you can work toward making some of those changes.
I really like the suggestion they had to have scripts for the front office workers and when scheduling appointments. I think that's a great way if there's physical barriers that are going to create a lot of time and expense, an investment that should be done but might not be able to be completed tomorrow or immediately, gives an opportunity to set up workarounds and maybe to meet the patient and help escort them into the building so that they can overcome some of those barriers, even if those physical limitations take longer to address. Just asking what some of the needs are when patients are scheduling appointments, I think is a terrific way to immediately overcome some of the more difficult barriers that may be in place.
And just to go back to the main point of your question, Jay, which is like, is there someone that can come in and do these assessments? I really only talked about that from like a regulatory perspective. But yeah, like organizations that are focused on disability access and rights, they are going to have individuals and resources to help you do those assessments, or to come in and kind of do an assessment themselves and give you some recommendations on how you could improve. And so connecting with those groups is always a great idea if you are serving a clientele that includes people with disabilities, because it can just provide that new set of eyes and that new perspective that you may be missing working from the inside out. And they have a lot of experience with those resources and best practices to meet the needs of your organization and kind of right size those solutions to what you really feel like you can effectively implement.
Questions? see anything in the chat. Well, if there aren't any other questions or anything like that, we can adjourn early. Again, we thank you for adjusting with us with the schedule. We will meet again in September on September 4th. And oh, Lauren, thanks for putting in the link to the MATRC. Appreciate that. And if there are any questions or anything like that in the meantime, before we meet in September, if there's a topic you want to hear about, or you have a case or what we call a case questions, please don't hesitate to reach out. We're happy for those. But if not, we will see you on September 4th. All right, everybody, take care.
Thanks so much,
Bye.
Jay.
See ya.